can stay on mute unless you're speaking. There will be a presentation. There will be an opportunity at the end of the presentation for you to ask any questions of the speakers. So when we get to that point, if you can please do the usual and raise your hands, say who you are and the organisation that you are from. We'll be monitoring the chat function, so if you've got any comments that you want to make, please do make them in the chat function and we'll be picking those up. The meeting's been recorded. We will share the recording with the slides on the UKOA website after the meeting. We'll send a link out to all of you so you can find it easily. Next slide, please, Helen. So this is the agenda for today. So just a bit of a welcome from myself. There's going to be a brief update on the UKOA. That'll just take a few minutes, and then I'll be handing you over to the team from the Royal London, who very kindly agreed to provide us with a really interesting presentation on their paediatric ophthalmology department and the child-centred approach that they've taken to the care there. And I believe we've got 3 speakers that we've listed there that are going to be talking you through that presentation, but you will meet them in a second. Thank you. Next slide, please, Helen. So just wanted to give you an update on membership fees. So unfortunately, as ever, we're telling you that we haven't had an avalanche of member fees in this financial year. It's been a constant state of having to chase trusts for payment, reminding them, answering questions about how they should pay and where they should pay, and further questions about what the UKOA does. We've had a board meeting on the UKOA board meeting on the 1st of December, and we had a discussion about it, and what we think is probably happening is we don't think that the invoices are necessarily going to the right people in the organisations, so that they can be acknowledged, the people receive them, understand the importance of paying the UKOA member fee. So they're just going around the houses in the trusts and not really getting paid or sorted out. So what we've agreed to do, and the board members are going to be helping us with this, but we would ask if you could email us or even put in the chat box the main ophthalmology lead contacts for the trust that you work in. Then what we can do is, if we haven't received payment from your trust, we can probably send the invoice to those ophthalmology leads and hopefully they can progress payment for us. So we really appreciate if you can give us the name, the lead ophthalmology in your trust, the name of the trust in the chat box, or if you can email the UKOA mailbox with that. It may be that your trust paid, but obviously we don't want to put here on the screen who's paid and who hasn't paid. So, but having those contacts regardless would be very helpful for the stakeholder list that we maintain. We did have one originally that was put together about 4 or 5 years ago. We understand that people have moved on, so we don't think we've got a great up-to-date list. That would be fantastic if you could do that for us, please. Thank you. Next slide, Helen. So this is just a brief update on the meetings up and coming. So we've got obviously today Royal London. We've got our next face-to-face meeting, the one that should have happened today, is now taking place on the 1st of February. Same location, it'll be at the Wellcome Trust. David Clark, the Chief Operating Officer at RNIB, has kindly agreed to host and chair that meeting. There's a really interesting agenda, which I'll show you in a second. We've then Veronica Greenwood, who's one of our board members, has put together a fantastic presentation on extended and advanced practice in paediatric ophthalmology, which she will be presenting on the 17th of February. And then Mary Freeman is also putting together a great presentation with a focus on nursing for the 21st of April. If you haven't already accepted the invites to those, then please do, just so we can get a general idea of how many are attending. It's really important that we know how many people are coming on the 1st, because we provide lunch. It's a room with limited availability. So if you are interested in coming on the 1st, if you can please make sure you let us know and accept the invite for that. Thank you. Next slide, Helen. We will also shortly be writing out to you with dates for the further meetings for 2023 and also for early 24. We're really interested to hear if there's any topics that you would like us to cover, or indeed if there's an interesting area of work that you've been doing in your trust that you think would be of interest to our members. Then we're always reaching out and trying to find people that have got innovative things that they're doing, interesting new ideas that they could share with members. So again, if you can let us know if you've got any ideas for topics, or indeed you've got some work that you're doing that you'd like to share, can you please pop that in the chat box, or email the UKOA mailbox? That would be great. We're also going to be asking members at the face-to-face meeting on the 1st of Feb for ideas of useful topics. So we're getting together for a really good meeting on the 1st of February. It's a packed agenda, but obviously it will be an opportunity to just start thinking about really interesting topics for future meetings as well. Please respond to the invite for the 1st of February. I'll say again, thank you. Next slide, please, Helen. Okay, I know this is small, I apologise, but hopefully when we circulate them, you'll be able to see this a little bit bigger. So I'm not going to go through this in any sort of detail. I'll just hold that there for just a minute, so you can see some really interesting stuff. Very much focused on patients, this members meeting face-to-face. We hope to see as many of you there as possible. These slides will be circulated, and this agenda will be circulated as well further. Melanie.
Yeah, so I just wanted to let everyone know. So as part of this day on February, we're going to be spending some time looking at the work that the RNIB has been doing, and quite a lot of you may have been involved as stakeholders in this, around this kind of eye care support pathway, like sort of a pathway to support patients that matches the new style of eye care pathways that we have in the modern era. One of the things that I think is being looked at as part of that is some sort of patient app or patient portal to sort of support patients through their pathway. So as part of that, because I think nobody wants to either reinvent the wheel or to duplicate what other people have done, we're really interested to hear from any members, any trusts that anyone knows about who have got a patient portal for ophthalmology patients, or who are very far advanced in developing one. I'm pretty sure that that Moorfields was well on the way to doing that, but I don't think we've launched it yet. But I think if anyone else has got one or is developing one, we'd really like you to get in touch, just so that we can sort of see what you're up to, and potentially, if people are available, we might be able to find somebody who could share a little bit about how they've done that and what they've learned. And we'll send an email out as well, just sort of asking people for that. But if anyone either knows about this in their own place or knows about somebody else who's doing it, do let us know. Thanks, Alison.
Very much. Next slide, Helen.
I think that's it.
I think that's it. I was just about to say that's the final slide, isn't it? I will finish here, and I'm now going to hand you over to colleagues in the Royal London who will take you through their really interesting presentation. Thank you very much.
Thanks very much. I hope you can see my slide.
Can you maybe put it on slideshow, Ashwin, if possible?
Yeah. Can you see it?
Yeah, perfect.
Yeah, great.
Yeah.
Okay, that's a good start. Well, thanks very much for the invitation to speak. I'm Ashwin Reddy at the Royal London Hospital, and we saw a discussion about paediatric ophthalmology and UKOA, and we'd just like to share our experience at the Royal London Hospital. Now, I'm going to introduce my colleagues, who are Zishan Naeem, who's Deputy Head Orthoptist, who will be speaking, and Polina Idzeva, who's our Principal Optometrist. So I'd just like to talk about developing a child-centred paediatric ophthalmology service in a situation where you don't actually have many doctors. And in fact, because I'm on the Council for the Royal College of Ophthalmologists, there's actually not many paediatric ophthalmologists as well. So this is a situation that I confronted nearly 20 years ago, and I'll just tell you how we addressed it, as it might be useful for others who are in the same boat. So this is at the Royal London Hospital. Barts Health is a trust, and there are several hospitals. So when I started, many years ago. It was in Tower Hamlets, and it still is, obviously. Tower Hamlets is one of the most deprived areas in the UK. It's a diverse population with about a third being of Bengali heritage. And at the time, many of the parents didn't speak very good English at all. So it was very difficult to communicate and to get messages across and so forth. And when I arrived, the paediatric ophthalmologist was a bit of a disarray. So this is just an example of our play area at the time. And you can see, you know, the toys are very grubby. And I had young children at that time as well. And I wouldn't allow them to come into this play area. So I couldn't understand why the kids who I was seeing in clinic had this sort of play area at the time. So there are real issues there. And because it's a deprived area, as we find, compared to richer areas, the patients and the parents, especially if they don't speak very good English, have difficulty explaining what the issues are. And so we had to act as advocates for them. And this is just from a paper we wrote in 2009, just showing how diverse the population was that we saw. And as you can see with the Bengali group, so let's get to the old laser pointer. So the Bengali group here is the largest group. And if we look at the English Scottish, that's sort of white is this sort of group. And there's lots of other groups as well. Right. So this is where we were. And this is an adult and children's area all being shared, so it was difficult. You can and so definitely not child friendly. And also, it was very difficult to recruit to this area. And you may ask, why is that? Well, when you arrived at Whitechapel Tube, you'd see this sign: beware muggings occur in this area. So it's difficult to recruit. Also, it was dysfunctional. There were lots of complaints going on between we had one optometrist who wasn't really seeing children. And also within the orthoptist department, we only had a couple of orthoptists. There were lots of disagreements and unhappiness going on. So it was pretty difficult. And when we had the odd fellow sometimes coming from Moorfields, and this was the worst experience that they had compared to working at Moorfields or any other centres around there. So it was a pretty unpleasant environment, really. So there are two aspects to this: infrastructure, which I know is difficult to change, and then also specific clinics, or specialty clinics, should I say, where we should be, where we could get people motivated. And at the time, we didn't have any. Well, I had 2 sessions per week to sort out paediatric ophthalmology. And you may ask, well, I'm a paediatric ophthalmologist. That's not very long. So, but I do something called retinoblastoma, which is a children's eye cancer, and that occupied at least half of my job plan. And I also do retinopathy of prematurity screening and treatment, which is a major has a major impact. So it's actually 2 essential clinics per week to try and sort out the volume that we had in paediatric ophthalmology, which, as you can imagine, is not easy for for a doctor if we had doctor only situation. So how do we go about sorting this out? So remember, we're still in that old building, so we had weekly service meetings and we had child-friendly clinics. We try to make it as child-friendly considering the environment. So we obviously had to sort things out like the play area, etc. So the infrastructure did change, I'm happy to say, back in 2011. And this is our new building, which we're paying a large mortgage for. And it's a very nice place to work. And you can see we've got nice clinic rooms now. It's a very child-friendly environment. And actually, we're all on the same floor as well, and much more airy and child-friendly. And this is our new building for the Royal London Hospital. However, when we were setting this all up, we didn't have this nice new building. So we were in the old building, and we actually looked at our clinic group at the time. And we found that we had a lot of patients with ocular genetic disorders, about 13% of the clinic population. And we looked at that in a paper in eye. However, we need to be aware that this, obviously for these cases, only doctors will have the level of experience and knowledge to deal with them. And they take a lot of time to sort out. So we needed our colleagues, our allied health professional colleagues, to be involved, to allow us the time to provide a good service for the patients that really had severe visual impairment or visual impairment associated with these sort of conditions. So we created these child-specific clinics, and the first one was the Paediatric Ophthalmology Primary Clinic. So initially we had optometrists, so we actually tried to get doctors, associate specialists involved at the Royal London. We actually had money for it, but we couldn't recruit. So we had to create extended role optometrists. Initially they were from Moorfields, and then we managed to integrate that at Royal London Hospital, specifically for Royal London. And then we created a Down syndrome clinic so that we could provide the time and make it more specific for kids with Down syndrome. Hearing impairment clinic for children who had hearing impairment. And obviously they've lost one sense, so their eyes are really important, their vision is really important. And we also had the additional needs clinic, which was more consultant-led for them. And also outside the hospital. So we started special school screening, and we got very involved with school screening as well within our area in Tower Hamlets. And we did transition, and this is really related to the allied health professionals, because it's very difficult to get actually a consultant who does cataracts or adult ophthalmology interested in adults with learning disabilities. So what we had is we created clinics that were led by our orthoptists and optometrists who have a great interest and are excellent. And then they have someone they can liaise with, and then we nominated people for that. And also, sometimes we have children who are very difficult to examine, and adults. And having optometrists with the appropriate skills to go and perform the examination under anaesthesia, for example, if they're under the dental unit, and then and they're having maybe their teeth sorted out, and then one of our optometrists can go, which frees up the doctors who may actually have a clinic or operating somewhere else. So it's a really valuable resource, and something we can really give to our patients, having these allied health professionals who are well trained to assess these patients. And also we're going to talk a little bit about our play specialist team. And, you know, all these things, we're always battling for everything. And our iClinic liaison officer, you might think, well, you must have had that back in 2008. Actually, we got the iClinic liaison officer in the last few months. So it's always a battle. None of this is easy. And it's a case of having a team that work together. And those weekly service meetings, I think, really help to push things forward. So I'm going to introduce Zishan Naeem, who is our Deputy Head Orthoptist, who will speak through some of these clinics now. Okay, Zish, you're on.
Right, thank you. Thanks for the opportunity to be able to share our experiences. The POPSI clinic, so the Paediatric Ophthalmology Primary Care Clinic is what we call it at the Royal London. I'm sure other colleagues have a very similar sort of model. I know at Moorfields you have the CBC clinic, having worked there in the past as well. And it's really a clinic that's really been quite beneficial for our service. It's an orthoptic optometry led clinic, and we also have our paediatric nurses on board as well to help with dilation. And it's been great for us to have the autonomy as allied health professionals to be able to assess patients who are, I suppose, quite straightforward in comparison to maybe some of the more complex cases that would come through to paediatric ophthalmology clinics for the consultants. We have 3 clinics a week, so we have sort of 21 patients sort of a week that we see, and already that hopefully would give you some idea of the fact that that's 21 less patients that are then going through the paediatric ophthalmology clinic route, for which sometimes we have had significant, waiting lists and things, and if these are patients who've got squints, suspected squints, reduced vision, possibly even concerns of an absent red reflex, then we really needed to have had a quicker way for these patients to be coming through the door. So how we receive these referrals is I vet these referrals via the e-referral service, ERS, which I'm sure is known to us all, and the referrals that come mainly from GPs, but we also get them from other health professionals, school nurses as well. And what we find, what I've been finding with this is that it's a really good way of us using, let's say, the advice and guidance section of the e-referral system, because if there are any referrals that perhaps aren't necessarily appropriate to be seen within our service, and therefore taking a precious slot which someone else could be using, then I can provide that advice and guidance, and suggest for the GP to perhaps provide some photographs maybe for a pseudo squint type of case, or for the opticians to perhaps allow for some more refractive adaptation before we then accept the referral at the hospitalized service. And quite often, sort of in recent times, I haven't been afraid to reject some referrals as well, which we just know aren't appropriate for the hospitalized service, and actually they can be appropriately managed locally at the opticians, for example. And we've seen a real benefit from having this clinic. As Mr. Eddy was saying, as Ashwin was saying, we've had this now for many years, and actually it runs really well. The optometrist and the orthoptist, we tend to have our own separate rooms, sort of along the same corridor, so we can have a discussion afterwards. So once a refraction's done by the optometrist, they tend to then come and find the orthoptist, and we have a very open discussion about the patient care, just to kind of make sure that the child's benefiting from the right kind of refractive error, refractive correction, in line with kind of the orthoptist findings of the squint and binocular functions, etc. We find that we've got, with the 3 clinics that we have a week, we find that matches our demand quite well, but there's also the scope for us adding on any ad hoc clinics where we can, where we know we've got sufficient orthoptic and optometry cover. We can then add on clinics to then match the demand, and it's definitely been relieving the paediatric ophthalmology clinics, because it means that we know that they're more appropriate complex kind of referrals that are being seen, and therefore our ophthalmologists are their skills are being utilized in the most appropriate way, rather than refracting fairly straightforward amblyopes, let's say, as an example. And it just means that these fairly anxious parents of children with a suspected squint, possibly an amblyopic eye, they're not having to wait off the back of a busy waiting list, which perhaps is there with the paediatric ophthalmology clinic. We usually get these patients seen within 13 weeks of referral to the service, so we've been pretty good with that. And if I could get the next slide, please. And the referrals, quite a few of the referrals that we get through to the POPSI clinic are from school screening. So we have a school health team in our borough of school health nurses that are trained by us.
Hello, lovely.
We
How you doing,
we train them so that they're able to sort of competently assess visual acuities, and that's at the reception sort of 4 to 5 age group. And we accept referrals from them if there's an interocular visual acuity difference of sort of greater than 0.2. So 2 lines difference, or if their vision's below 0.2, if there's a suspected squint, or if the assessment's particularly limited. So again, this just means that we're not just accepting all referrals from school screening with reduced visual acuities, because if they're bilaterally reduced visual acuities, they can of course go to the local opticians, be refracted locally, and then from there, if there are any concerns, then they can refer to the hospital eye service. Our orthoptists and optometrists have audited this over the years, and we found that we've got as high as a 70% sort of true positive referral rate to the POPSI clinic, and actually this hasn't been re-audited in recent times, just given the sort of backlog from the pandemic and things, but something that's being done at the moment. And where we found that there are false positives, because we have such good relationships with the school health team, we're able to train them and provide the feedback. So we sometimes on a Monday morning have the nurses, school health nurses, come in to observe and just sort of see how the orthoptist uses our very sort of specialist skills to be able to assess children's visual acuities, especially in the more kind of trickier scenarios. If I could just get the next slide, and I'll hand this over now to my colleague Polina, who's the principal optometrist over at the Royal London.
Thank you, Zish. I hope everyone can hear me. Thank you for the opportunity to present today and to be here. So I'm just going to talk about the special school screening which we perform. Is usually one orthoptist and one optometrist who go to school. We do this usually on a Wednesday, so 1 day a week, pretty much every week, and we take our own equipment, so portable equipment usually we take. Patients assessed are age group of in between 4 and 19 years old, and assessing them at school, so it's beneficial for them to feel more comfortable. Therefore, we get better cooperation as they're in their own familiar environment, and less distress. So the orthoptist performs a complete orthoptist assessment, and the optometrist performs either dilated or undilated refraction and fundus check. These children with usually developmentally delayed children need an ophthalmic assessment, so to ensure that the vision is not impaired, and if so, and is not impacting on their function. We usually get a consent form beforehand from the parents, and there is a big range of apps and consent forms. So we are trying to battle with this so we can perform the tests. We currently go to 3 schools, which are the Phoenix, Beatrice State, and Stephen Hawkins. The rough number of patients we are currently seeing is on the top. So Phoenix is the biggest amount of patients. We have not been going to schools for the past 2 years due to the pandemic, so this has affected these children. And what we've decided to do is that, so we've divided the Phoenix school, for example, we're seeing half of them in 1 year and the other half on the following year. The Phoenix school is mainly children with autism, and Beatrice State and Stephen Hawkins is more complex health conditions, which often need ophthalmological assessment. We usually know the medical history for the patients, but this is not always the case. And at Phoenix school, we rarely can dilate patients as there is just no cooperation for dilation. So we see them mainly undilated, but at Beatrice State and Stephen Hawkins, we tend to dilate them because it's important due to the associated health conditions. And next slide, please. So we have previously audited the school screenings, and what we have found is that at Phoenix School, the myopic range was mainly between early teen age, and the degree of myopia was higher in early school age, so in between 5 and 6 years old. Also, some of the main general conditions we've seen is epilepsy, cerebral palsy, and some global developmental delay. Next slide, please. What we are mainly doing is a screening program. So therefore, if we tend to give an outcome to every patient, so the outcome is either pass or fail. We ask the teacher to put a pass or fail sheet in their bag, so therefore the parents can see if they passed or failed the exam. The past patients, we tend to see them again in a year's time when we go back to school, and the failed patients, we usually specify on the sheet why they failed, and we either say that we will contact the parents, so to talk to them, or we write down that we will book an appointment for the hospital, so they're going to be seen at the hospital. At Stephen Hawking School, so the audit showed that the refractive error was, for example, mainly astigmatism, what we could see, and in second place, myopia, and then third, hypermetropia. The most common squint was exotropia, and we saw quite a few numbers with squint, so with strabismus and astigmatism or other fundus abnormalities. And the third school, next slide, please. So at Beatrice State, for example, again, we saw so many children with global developmental delay and autism, microcephaly, and cerebral palsy. For most of them, we did not know the family history. The exams performed by the orthoptists were successfully the visual acuity cover test, convergent tests. But for example, stereopsis was not possible to be performed in most of the patients, so due to their learning difficulties and developmental delay. And most of the patients had actually the cycloplegic refraction. A very small number of patients who did not have the cycloplegic refraction. These numbers and outcomes are currently changing, and we still need to re-audit this post-pandemic to see what has changed and what continues to be the same. Next slide, please. So another interesting clinic which we currently do at the hospital is Down syndrome clinic. We do this clinic, we usually have, it runs alongside a consultant-led clinic. So therefore we get the support if it's needed for, if there is more complex needs or any difficulties in the assessment or for any other reason. So these are usually Down syndrome patients who are referred from pediatricians, GPs, opticians, or other hospital units, and it happens once a month. More likely they have difficulties with their eyesight, or they need, and most of them do need to wear glasses. Now we have mentioned here also that the UK Down Syndrome Medical Interest Group suggests the exams to happen at birth, from birth to 6 weeks, so to exclude congenital cataracts, from 18 to 24 months for a formal exam and vision check, including squint, rule out, and refraction, and for age around 4 years old for a formal eye test, a vision exam, including so orthoptics check for squint, the refraction, and assessment at near and distance visual acuity, and school-age children to repeat the vision test every 2 years or more frequently if recommended. At the moment, we're running this clinic, so we tend to see the patients once a year, if possible, unless they require a closer follow-up. And we make them feel more comfortable with familiar environment to them, and also they have patients around them with similar needs, which makes them feel more compliant, more in their own environment. The following clinic we have is, next slide please, Mr. Reddy. Hearing impairment. So this is another clinic we run alongside the consultant-led clinic. Is a screening service again with for children with bilateral hearing loss. They usually get referred from the ENT department, and this also happens once a month. So they get an orthoptic assessment, dilation, optometrist examination with refraction and health check. The patients are also seen usually annually. We tend to tell them if there is any problems to just get in touch and see them earlier. And we also refer to electrodiagnostics test if when they get to a suitable age, usually over 8 years old, or if we see that that's clinically needed. So for example, for we refer all patients for ERG testing if there is an explained congenital bilateral severe to profound hearing loss, if there is any cochlear implants, or they're being referred for cochlear implants, and any relevant symptoms or signs suggestive of Usher syndrome, like night blindness, visual fields loss, unexplained reduction in visual acuity, any pigmentary retinopathy, including the white dots. And there is also a paper which has been published with the Mr. Reddy being involved and one of our previous optometrists. And this paper is about the electroretinogram assessment for children with sensorineural hearing loss and the implications of screening. So as the guidelines of the National Deaf Children's Society recommended that children with sensorineural hearing loss need to be routinely screened for any ophthalmological problems, and they suggested the ERG to exclude the Usher syndrome. So we saw on the results that, for example, 84 cases which met the inclusion criteria, 15% of those patients, the ERG findings showed some rod cone dystrophy, which was consistent with the diagnosis of Usher syndrome. And 2 patients had retinal pigmentary changes, normal ERG. Well, they were diagnosed of rubella retinopathy based on the clinical findings. And it seemed that a risk factor analysis showed that over 8 years old patients at that time of having the ERG, so it was not predictive of diagnosis for Usher syndrome, but the presence of referral for example, cochlear implants and having the relevant symptoms or clinical signs, it was consistent with the retinal dystrophies and profound hearing loss. So that was highly predictive. Therefore, ERG, so the conclusion is that ERG is useful diagnostic tool in children with sensorineural hearing loss, and it should be performed in children who have that diagnosis and who have cochlear implants and or some suggestive signs of retinal dystrophies. Next slide, please.
Okay, I'll speak a little bit about this, Polina. Yeah, so additional needs, we used to call that special needs clinic. Now, we just recently changed it to additional needs clinic. This is more consultant-led, and we are trying to transition this to a more optometrist-led clinic. And when we set it up back in 2007, we actually had pediatricians and visual impairment teachers come in. And the issue with all of these things, it wasn't funded, and it was really on goodwill in our admin time that we created this. And then we created a low visual impairment pressure group in Tower Hamlets on the back of this, really to support children with poor vision in Tower Hamlets and those who often have cerebral visual impairment. So in Tower Hamlets, we have at the time, and still, we have a high level of prematurity, and that will give high levels of cerebral visual impairment. And obviously, you have kids with complex general health conditions. So we use dorsal and ventral stream dysfunction, specific questions, and we have 2 clinics a month. And really, the clinic's designed to provide a familiar environment for children, so they don't have to wait too long, and they're seen relatively quickly. And on the back of this, there's this group called Doves that has been created. We lobbied the Tower Hamlets Council at the time for a place where children and families could go, and that's been created now. And there are some proactive individuals within Tower Hamlets who really want the kids with low vision and complex disorders associated with low vision to have really good treatment. And so we don't have to act as a pressure group anymore because it's happening already. And what we're hoping in the future is to get more orthoptist-led additional needs clinics, and we're working towards that with a questionnaire for them. Okay. So now play specialist team. So Zish, do you want to talk about this?
Yeah, so I think with a lot of these sort of patients that we have with additional needs, and even actually just sort of children who may be coming to clinic with sort of anxieties about coming into the hospital environment, or being unsure and uncertain about what's about to happen, they then obviously find it naturally very difficult, and it affects their cooperation and then therefore our assessment and our findings. So we're quite fortunate that we've again, on the same sort of corridor, we have the play specialist team who are seen as allied health professionals in their own right as well. And these are a group of our colleagues that we do sort of sometimes heavily rely on, so that they can actually sort of use distraction and play as a means of improving cooperation. And it's really sort of looking at enabling the child and allowing them to sort of feel like they're in control. And we've definitely, I can speak on my own experiences that I've seen some really good solid sort of improvements straight away. As soon as they come in, they just have such an impressive calming nature about them, and it just means that we're then able to, let's say with a patient who's undergoing patching treatment, if they've got dense amblyopia, let's say, then we can actually we're able to assess them in the way that we need to be able to get the results that we need to be able to then manage them appropriately as well. So they can be bleeped whenever we need them, so they're not sort of kind of in clinic, as it were, but they're down the corridor, and we can always sort of ask for them when we need them. We do use them within our sort of retinoblastoma service quite well as well, but appreciate that's a separate service that we have. Next slide, please. And as Ashwin said, we're very lucky to have finally our ECLO in place. I know Liz Tomlin's on the meeting as well, so I must use this opportunity to thank her as well for putting us in touch with guide dogs so that we can actually sort of utilize their services. And it's really so that we can make sure that the needs of our children are being met to the full, especially in their sort of school environments in particular, so that they can actually access their learning and their curriculum in the best possible way. And we have our ECLO Eric, who provides various support. So he sort of manages the CVI process for us, as do all ECLOs, provides sort of the emotional sort of welfare sort of support side of things. Before we had Eric joining us, I, as well as the other orthoptists in the team, we felt that we were doing a lot of this sort of liaising with vision impairment teams locally, and sort of liaising with other sort of professionals in the community. So it's just kind of allowed us to relinquish that and actually focus our attention on, you know, orthoptic led clinics and various other things that we want to be doing. There's also the signposting to other charities and organisations that's done by the ECLO as well. So yeah, we've found it extremely beneficial having our own ECLO. We also are fortunate to enough to have a support worker from another organisation, the Royal Society for Blind Children. So we also have their sort of support, and we work very closely with the sort of team lead for the for our Borough Tower Hamlets visual impairment team. So it means that we're always in touch with them with any patients that we feel meet the criteria for their referring for their referrals. So it means that we're making sure that our children are sort of being asked, parents are being asked about this in their appointments to make sure that our children, our patients, are being supported in the community. Yeah, we have them in clinic 3 days a week. So that's basically whenever we have our paediatric ophthalmology consultant-led clinics, as well as the retinoblastoma clinic as well. So we're making sure we're capturing as many children who may require their services. And back to you, Mr. Reddy, for the next slide.
Yeah, so I think we're going to have to speed up a little bit because we've got to have some questions before 12. I think it's a hard stop at 12. So do you mind, yeah, so sorry to put you under pressure, Zish and Paulina, do you mind speeding up along a little bit?
Yeah, this is for you now, Mr. Reddy. So this is your slide that you were going to discuss.
Yes, this is just to emphasize, we recently had a grotto led by guide dogs. And if we have time, we can do this video, but let's go through the slides. Oops, let's stop that. And this is from ITV News. And we had many of our patients here. So I'll just forward this a little faster.
Can't hear it, can we?
So that just gives you an idea of, you know, our patients now have access to that through the ECLO and through guide dogs. So that's really making a difference there. So do you want to just say a couple of sentences about the low vision service, Zish?
I'll actually take over if that's okay. So
Paulina, yes, sorry, Paulina.
The pediatric low vision services that they're usually patient supported by the ECLO, very limited numbers at the moment, so they're locally supported mainly. And the mainly patients from the RB service. This clinic happens once a month or when needed, and they're assessed for their day-to-day needs, school and social needs. They're usually provided with hand or stand magnifiers and telescopes, but they are mainly up to date with technological devices supported by the VI teams or the education, health and care plan.
Cool.
And this is the transition clinic we're having between adult with children with learning disabilities and adult with learning disabilities. So the transition is in between the pediatric clinic to the adult clinic, usually for patients in between 16 and 18 years old. And it's we have a design consultant to support the clinic, but it's actually led by orthoptists and optometrists. So orthoptic examination and then an optometrist refraction and fundus check is performed. Usually we see them once a year. And a few patients who can have their examination in the outpatients clinic. So some of them who need, for example, dental assessment, as Mr. Reddy mentioned earlier, they go under examination under anesthesia, and we can assess their eyes. So that's why we work closely with other specialty for children with these complex needs, and we can assess them together alongside with their either dental or gastric examination, and they're usually referred by the dental team.
This is just a slide showing the team. So it just sort of shows sort of the sort of how we span as a team, and we work closely with one another and other sort of MDTs as well. So we have an MDT approach, and we started out sort of seeing sort of 1,500 children in the service, and now we're seeing sort of 11,000. So that just sort of shows I guess how our service has grown from those early days mentioned at the start of the talk. And the next slide is we've just provided our email addresses there if there are any specific questions, but we know we've got the chat facility of this talk. And I'd say that with the video we can provide you with the link if you'd like to view that. So I know there were problems with the audio, but yeah, just wanted to thank you all for the opportunity to share our experiences, and we're happy to take questions and answer those.
Thank you ever so much. That was brilliant. Actually, Ashwin, if you could unshare that, yeah, so we can all see each other. That's brilliant. No, so I was putting in the chat. So I remember this, the pre your team era. So there were quite a lot of consultants going over, not just peds from Moorfields, to shore up the Royal London, because it was just having a bit of a bad time. And I used to go with Professor Moore, who was mentioned in your paper as the fellow. And yeah, it just was grim. And of course, as visitors, you're not going to develop the service, are you? Just sort of stop it from being disastrous at best. So it's amazing to see what you've done since that time. It's a real journey. I think you can't underestimate, no doubt, the battles that you've had to do it. So well done. I just was one quick question for me, then we can ask a couple of questions from the chat. You know, your paediatric clinic, and you were saying that's near to the eye clinic. Is it part of a paediatric outpatient suite? In other words, are you part of a general paediatric unit there?
So very good question. So it's all infrastructure now. It's fantastic infrastructure. So basically at the Royal London, we've got a building with lots of floors, and there's 3 floors that are devoted to paediatrics. So there's no mixing anymore. So our paediatric ophthalmology clinic takes place there in a particular area, Clinic 2, and we share that with ENT quite often. So it's a paediatric clinic with all our kit in it, but ENT will use it sometimes. And there's very few other specialties that are using that area.
Fine. So it's a paediatric.
Yeah, it's paediatric. Yeah, proper paediatrics. Yeah.
Cool. Ian, do you want to ask a question?
Yeah, hi Ashwin, hi Paulina. Thank you very much. That's impressive, and it's great to see. Like this is about the whole journey, and you get that impression of the whole journey approach. Now, my question is about of course about the patient experience and how we sort of factoring that in, because it's fantastic and it's very intuitive to see those improvements. But are we sort of doing a bit of systematic feedback, and that feedback can be quite broad these days, can't it? It can be quite clever, the methods that we use.
Paulina, would you like to say something about that?
So we actually have previously audited the patient's experience, and this was actually a very good question, a good point to mention here. I think generally our patients are very grateful, and they do attend their appointments, and they look forward to see us and to share so what has happened to their children within the time we haven't seen them. And they pretty much know the whole team. So every year when they come, they acknowledge us, and they actually say, "Oh, I see. I actually saw you last year, you're this person. And it's really nice to hear from parents that they're happy with the service and so on, but it's actually something which we are thinking of re-auditing. So to hear again.
Brilliant. I've got a question from Victoria from Wirral in the chat, and I'm just going to add to it. So she's just asking about, I think you did mention this, about you work with your VI teachers, I think, don't you, in your additional needs clinics, whether is that both in the community and the hospital? And also I was going to ask, because when I did this sort of thing in Cambridgeshire, another person we used to invite to some of them was the community paediatrician, the consultant, and they were really helpful actually to join it up with the rest of the sort of child. So just asking about those.
Yeah, so initially we had all these back in 2005 to about 2012, but a lot of it wasn't funded, and that was the difficulty with all these things. But now we have very good relationship with our visual impairment teachers. Zish, do you want to make any comments about that?
Yeah, so we've got one of our specialist orthoptists. We've used them as our sort of a point of contact for our visual impairment teachers. So if there's any queries or anything, that they just email us directly, and then we can kind of keep that sort of bridge that gap and make sure we provide, obviously with consent having been taken from the children, from the parents, and we share that information. I thought it was a good point that we could have them sort of attending appointments as well, especially for the more sort of those who have very specific needs. That would be quite a useful thing. I'm also the lead orthoptist for the retinoblastoma service, and I know that I work quite closely with visual impairment teachers, but they're all over the UK, so we would have to sort of arrange for them to attend appointments. But no, a useful point. Thank you. Good.
I'm just going to slip in one more before we sort of finish. I'm sort of staring at Lauren, who I work with really close from Moorfields, who's just been appointed. So many of you may remember Mally Scrutton, who was our paediatric matron for years at Moorfields, but she's sort of gone to pastures new now, i.e. to enjoy herself. So Lauren's sort of taken over as matron, which is great. And she will know that one thing that I'm obsessed with is trying not to see people who don't need to be there. And I was really interested in this kind of thing about rejecting referrals, because I think it's still something we struggle with actually in Moorfields. I think a lot of people struggle with, and then, you know, parents kind of go, but I'm very anxious and I want to be seen. So I was interested if you talk a bit more about how you've sort of got that robustness, particularly, you know, without having to use the consultant every step of the way. And also for your referrals, do you get photos at all to help you make that decision?
We do receive photos, and if we don't, then I wouldn't be shy to ask for them. I think it's really useful to have as much sort of evidence as we can to be able to make the right call, or an appropriate call. Probably a bit more of a personal experience, I think. I'm not sure that it had been done before, where someone was perhaps as brutal as about rejecting referrals, but I just kind of, I think it was just I became lead during the pandemic, and I feel that I just wanted to see some more positive changes about actually seeing patients that we need to be seeing, rather than you know, it's very frustrating sitting in one of these POPSI clinics and having a patient in front who had only a lines difference in their visual acuity, and they were given refractive correction at their local opticians, and we're then seeing them back, and actually their visual acuities have improved. So actually it was a waste of an appointment, and actually a waste of their time as well. I tend to just sort of reply back to referral, reject, but with you know, substantial advice. I don't just sort of reject it with a line saying this is not appropriate. I'll usually advise them and say, this is why we're rejecting your referral. If you could, and then I'll make a suggestion. Perhaps this patient requires a bit longer refractive adaptation, and then we'd be happy to accept referral if the visual acuities remain reduced, something along those lines. But no, I think it's something that I want to continue doing, but obviously also being mindful that sometimes we can't just reject things if we're not sure, and in which case we would ask for more information from the referrer.
Brilliant. Okay. All right. Well, I'm going to bring it to a close now because we've sort of hit 12. So that was really interesting. Thank you so much. And I really think you gave us that sense, like I think you were saying earlier, that journey that you've been on and you're still on, and it's absolutely fantastic. And I'm sure that, you know, we'll share the sort of slides in the recording. You may find that people get in touch afterwards, as they often do after these things, just sort of asking more. And also we need to make sure that Liz's very kind offer to, you know, for people to sort of inquire about child-friendly ECLOs, which I think is quite a challenge to get for some people. We need to just make sure that that's highlighted. If you don't mind this, hopefully you won't be bombarded with questions, but I think people find that difficult. So thank you all very much, and I hope very much to be able to see many of you face to face at the meeting in February, and do pass on the invitation to all your colleagues. The membership includes all members of any trust or health board, and see you then. All right, thank you very much, and of course, happy Christmas.
Merry Christmas. Thank you for the invitation. Bye.
Bye.
Thank you. Bye.